Hello and welcome to the Risk Factors for Cognitive Decline Among Dementia Caregivers webinar. Thank you for joining us and being here today. My name is Kat Holcomb and I'm a specialist with the Bold Public Health Center of Excellence on Dementia Risk Reduction at the Alzheimer's Association. This webinar is co-hosted by the Bold Public Health Centers of Excellence on Dementia Risk Reduction and Dementia Caregiving and is funded through cooperative agreements with the CDC. In my role, I have worked closely with the Alzheimer's Association's risk reduction efforts, but have also worked with our co-host, the Bold Public Health Center of Excellence on Dementia Caregiving and leading a lived experience advisory group. So I'm so excited for this webinar, and again, thank you all for joining. We are thrilled to have you here with us today, so if you would in the chat, let us know where you're listening from, and looking ahead, what do you think is the most important way that public health can support caregivers? And while you are entering that in the chat, we will go over just a few housekeeping things before we get started with the webinar. So as a reminder, the recording will be shared with all registrants, and any personal use of recording the webinar or use of AI assistance to record is not allowed. If you would like to use the closed captioning, you can enable it using the toolbar at the bottom of your screen. And please feel free to put any questions you have during today's webinar in the Q&A box. Our speakers or someone from the public health team will respond. So for the webinar today, we will begin with learning objectives, hear from our presenters, and then end the webinar with the Q&A session. In the webinar, we'll learn about how caring for a person with Alzheimer's disease or another dementia can create new or worsen existing health problems for the caregiver, explore data about risk factors for cognitive decline and how they affect caregivers, and lastly, hear from the Minnesota Department of Health on integrating caregiver health and well-being initiatives into comprehensive strategic plans. To help us accomplish these learning objectives, we have 4 great presenters today. We'll begin with Dr. Joe Gogler, the director of the Bold Public Health Center of Excellence on Dementia Caregiving. We will also hear from Ben Dino, the senior health policy specialist at the Alzheimer's Association. And we have 2 speakers from the Minnesota Department of Health, Renee Kidney, the principal epidemiologist, and Patty Takawira, the Aging and Healthy Communities Unit Manager at Minnesota Department of Health. So without further ado, I will introduce Joe and pass it over to him.
Well, thank you, Kat. Thank you, everyone who is taking the time out of their busy schedules to join us here today. Really, really excited to be part of this webinar and to talk a little bit about the potential health implications of dementia caregiving. Probably as many of you are aware, the study of care and in particularly unpaid care, unpaid care often provided by relatives of those living with dementia. We know that that is really the core of long-term care in the U.S. for people living with dementia. Roughly 83% of those living with dementia in the U.S. rely on an unpaid individual, again, often a family member, to provide needed assistance. And with that, significant role in the care of people living with dementia has been really at this point almost 50 years of research describing the emotional, psychological, and health implications of caring for someone living with dementia. Now, at one level, the findings that I'm going to share with you briefly are pretty straightforward. I mean, it's pretty consistent across many, many surveys, including national surveys, when comparing a caregiver of someone living with dementia to a caregiver of someone living without dementia. And the care recipient may be of similar age, the caregiver may be of similar age, gender, et cetera. There tends to be a pretty clear difference in self-reported health as well as other health outcomes on the part of dementia caregivers. But as with all research in science, there's also some caveats to this too, which I'll get into very briefly. But since around, I want to say 2012 or so, or 2013, I've had the great honor of having authorship responsibility for the caregiving section of the Alzheimer's Association Facts and Figures annual report, which is chock full of key information. I'm sure many of you are familiar with that. If not, please check it out. The 2025 report just came out, I believe, a couple months ago. And in the caregiving section, we really go in depth in providing up-to-date statistics on the health implications of dementia caregiving. And this table you see on this slide is one example. This is table 11 from the FACT report. And this is a comparison, again, of caregivers of people living with dementia versus those caregivers of people without dementia, as well as non-caregivers. And you can see some significant, or at least important differences in key health conditions. Again, and it's not totally consistent, but there is a pattern here. So, for example, in stroke, you see a difference. Dementia caregivers are a couple percentage points higher than non-dementia caregivers. And again, that doesn't seem like a lot, but when one extends this to the entire population, it becomes important, at the very least, from a public health perspective. Cardiovascular disease amongst dementia caregivers, you see more higher percentage of prevalence. Diabetes similarly, as well as cancer and some other conditions as well. But again, it's not entirely consistent. Obesity, for example, both non-dementia and dementia caregivers are similar to non-caregivers. But again, this is coming from the Behavioral Risk Factor Surveillance System, a representative survey delivered by state departments of health on an annual basis. And again, these findings tend to be fairly consistent year after year. Next slide, please, Cap. So there are other key health implications to consider when someone is caring for an individual living with dementia. You see, for example, sleep and sleep disruption. Caregivers of people with dementia are estimated to lose between almost 4 hours more of sleep a week when compared to non-dementia caregivers. You also see close to, a little bit over a quarter of dementia caregivers delay or do not do the things they should do to maintain their own health. These are just some, I think, interesting statistics, again, in that facts and figures report, of which there are many describing the potentially adverse health implications of dementia caregiving. Next slide, please. Other key health dimensions to consider, the chronic stress of caregiving is associated with greater incidence of hypertension, as well as a number of physiological changes that can increase the risk of developing chronic conditions, including high levels of stress, impaired immune function, and slow wound healing, and coronary heart disease. So, I mean, when thinking of all this, some of this may seem somewhat obvious in that, yes, we know dementia caregiving is challenging. We know it's stressful. The point, I think, of this webinar, the point of this topic is when we think of dementia as a public health priority, we often are focusing on the person living with dementia. It's a little, in some instances, there have been questions raised, well, why is caregiving itself a public health priority? And in fact, you can make a very strong argument. It's a public health priority because of some of these findings. Clearly, there are potentially adverse health implications for caring for someone living with dementia, to the extent that caregiving in and of itself is potentially a health risk factor that should be addressed through public health intervention. And as we transition to later slides, Ben Deno from the association is going to go much more in depth in some of the recent findings that we'd like to share with you about some of these adverse health risks. Now, I had mentioned there's a caveat, and I think it's important to note that here today. There have been meta-analyses, and what meta-analyses are scientific studies that pool all of the empirical results of existing research together to try to answer a question. For example, to determine if a certain program or intervention is effective. Well, this has also been done to try to determine better, is dementia caregiving associated with adverse health? And when one maybe moves beyond these cross-sectional studies of caregiving and health, the picture becomes a little bit more complex. For example, some have speculated that, in fact, caring for someone living with dementia it's governed by what we would call self-selection, in that people who tend to assume caregiving roles for people living with dementia might be more healthy because within a family, for example, than others. And thus, when you look at some other findings, the picture isn't nearly as clear as to the longitudinal health effects of dementia caregiving. And again, I know this drives some of my colleagues nuts, maybe even on this webinar panel, when I add these nuances and complexities, but it is important to note that the science isn't definitive necessarily in saying, well, if you provide care for someone living with dementia, you're going to get worse health. That isn't always the case. The second thing I really want to recommend, it's been a big effort of our public health center, and I'd like all of you to think about is this. We have made great advances in creating representative national data sources to describe dementia caregiving, the health implications of dementia caregiving. And in some instances today, and what you saw me quote from today, these are indeed national data sources that we're discussing. When you start to look within state and maybe even on a more granular level, again, it becomes more complex. Again, there shouldn't be a shock to anyone, but dementia caregivers in one state, say Minnesota, aren't necessarily going to be the same as another, say South Carolina. There might be other key social determinants, social factors that could drive the dementia caregiving experience, and particularly dementia caregiving health. So that's another important point to keep in mind as we continue to move this field forward from a public health perspective. The need for more granular, localized data to help inform decision-making, policy, public health intervention is also critical. So I'm going to stop there, I believe, Kat, and turn it over to Ben. If we go to the next slide.
Yeah, great. Thank you, Joe. If you have
Okay.
any questions for Dr. Gogler, please put them in the Q&A box. And at this point, I will turn it over to Ben on the Alzheimer's Association team to hear about the data analysis.
Great, thanks, Kat, and thanks, Joe, for that introduction and overview of a bit of the state of the science on what we know about caregiver health related to dementia caregiving at this moment in time. As he mentioned, I'm going to go a little bit further into some new data, new being 2021-2022 behavioral risk factor surveillance system data from the caregiving module. This covers 47 states. That's every state except Florida, Montana, and Tennessee. Those 47 states successfully collected caregiver module data in at least one of those 2 years, 2021 and 2022. So we're talking about when we've aggregated all of these states together, a near national level basis. You'll probably hear me slip and say national at some point. We're talking about a near national 47 state data set here. We're going to look at 6 modifiable risk factors for cognitive decline that are measured in the BRFSS. That's diabetes, measured as being ever diagnosed with diabetes. Obesity, that's a calculated BMI rate. Physical inactivity, being no exercise outside of work. Smoking, being a current tobacco user. Poor sleep, being averaging less than 6 hours of sleep per night. And hypertension, which is only available in 2021. BRFSS only collects hypertension data every other year. So that is an ever diagnosed, but again, that's 2021 only, and that is a subset of the 47 states that collected data over the course of the 2 years. We can go on to the next slide. So for the rest of this presentation, or for my part of the presentation, dementia caregivers, as defined by the BRFSS, refers to caregivers who provide care to individuals for whom dementia is either the main condition or is a secondary condition to some other condition, any other condition. If they have dementia and someone is a caregiver for them, we are defining them as a dementia caregiver in this analysis. Across the 47 states, that gave us 13,565 caregivers, which is a pretty good sample size that we can do lots of different crosstabs and, as Joe mentioned, go into more granularity for these different subpopulations. Of all adults that took the caregiver module, a weighted 4.3% were dementia caregivers, and that was 20% of people who were caregivers of people with any conditions were dementia caregivers. We can go on to the next slide. So at an overall level, mirroring what Joe had mentioned that has been repeatedly found in previous analysis, we did find that dementia caregivers did have higher risk factor prevalence rates for these risk factors for cognitive decline. You can see on the left-hand side here, it's not a huge difference, 59.1% among dementia caregivers versus 56.1% among all adults. Proportionally, that risk is about 5% higher than the risk for all adults among dementia caregivers, but it's only about 3 percentage points higher in the prevalence rate, as you can see here. Again, hypertension data was not included in the combination of risk factors here, which we refer to as having at least one. So at least one will be the other 5 risk factors: diabetes, poor sleep, obesity, smoking, and physical inactivity. If we were to include hypertension based on some data that we'll go over later, we expect that this gap would have grown slightly between dementia caregivers and all adults. So we can go to the next slide. So the goal here is to dive into a bit about what's driving that prevalence difference between risk factors, the 59.1% among dementia caregivers and the 56.1% among all adults. Here we're looking at the individual risk factors and how dementia caregiver risk relates to all adult risk. You can see here that they're pretty similar going across the board in 5 of 6 cases, except for physical inactivity. Dementia caregivers do have higher prevalence rates compared to the all-adult average. Physical inactivity, they were actually 9% less likely to report having no exercise outside of work. And that may be part of what Joe was discussing before about a bit of self-selection on who is able to take on these caregiving tasks in the first place. But what we do see here is that the difference compared to all adults is greatest for smoking. Dementia caregivers are 30% more likely compared to all adults to be current smokers. And hypertension in 2021, that was a 27% odds ratio increase compared to all adults. But again, 20% more likely to have less than 6 hours of sleep, 12% more likely to have diabetes, and 8% more likely to be obese. So 5 out of 6 dementia caregivers were ranking worse. And we can go to the next slide. So on the right-hand side, you'll see a breakdown of the total population of dementia caregivers and how many risk factors they have. In purple, that 34.8% would be having just one, that 24.3% would be having multiple, and the 40.9% would be having none. So the purple and red add up to the 59.1% we saw on the first bar graph. And then breaking that down, 40% of people who have any risk factors, at least one or multiple, do fall into that multiple category. So that's about 1 in 4 dementia caregivers overall had multiple risk factors for cognitive decline, which is compared to 21.3% of all adults. So again, about a 3% difference in the prevalence rate and a proportional small difference, less than 14% to have multiple risk factors compared to all adults. And we can go on to the next slide. We also looked at race and ethnicity in BRIFIS. You can see here the purple bar is, again, the 59.1%, the all dementia caregiver average. And we can see that on the left-hand side, American Indian, Alaska Native dementia caregivers, Black dementia caregivers, and Hispanic dementia caregivers were ranking significantly or just slightly more likely to have at least one risk factor compared to all dementia caregivers, whereas white and Asian dementia caregivers were less likely to report at least one risk factor compared to the average. Going a step further, diving a little bit into what's driving these racial differences here, I did note that American Indian, Alaska Native dementia caregivers were nearly twice as likely to report smoking compared to the all dementia caregiver average, whereas Black dementia caregivers were 40% more likely to report obesity compared to the all dementia caregiver average, which is just to say that even here, where groups look similar, American Indian, Alaska Native, and Black, all the way to the left-hand side, it may be different factors actually driving that disparity. So it's important to look under the hood the further you go. So we'll move on to the next slide. We also looked at risk factors in sex. As with all dementia caregivers, both male and female dementia caregivers, more than half had at least one risk factor. That's 64% here for male dementia caregivers, 53% for female dementia caregivers, and about 1 in 4 had multiple risk factors for cognitive decline. We can see that in both for at least one or multiple, men were more likely to have risk factors compared to women. 15% more likely to have multiple and 15% more likely to have one. And again, for 5 out of the 6 risk factors, male dementia caregivers were more likely, or they had a higher prevalence rate and were more likely to have those risk factors. The exception being physical inactivity. Female dementia caregivers were actually more likely to be physically or to report physical inactivity compared to male dementia caregivers. And we can go to the next slide. So now we've looked at race, we've looked at sex, moving on to age. Again, we see that more than half of dementia caregivers, no matter how we slice it, have at least one risk factor for cognitive decline. Under 45%, 57.3. Middle age 61.5, and 65 and older 58%. Again, we're tracking about 1 in 4, between 1 in 4 and 1 in 5, having multiple risk factors across all age groups. But we will note there is a little bit of a peak, both for for reporting at least one risk factor and reporting multiple risk factors. The highest rate was actually among the middle-aged dementia caregivers, the 45 to 64, which is just contrary to what we might expect going into this analysis. And I'll explain a little bit further on the next slide. So here we're looking at age and having at least one risk factor. Again, across the board, all adults, dementia caregivers across all age groups, more than half of people have at least one risk factor. Under 45, we saw the greatest difference. Dementia caregivers were 13% more likely compared to all adults to have at least one risk factor. That relationship really moderates in middle age. 61.5 to 61.1% is basically no difference. And then by the time we get to older age, those 65 and older, this relationship is actually reversed. So we're seeing the dementia caregivers actually reporting less risk factors for cognitive decline compared to the all-adult average, which, again, I'll circle back to Joe's point about self-selection among dementia caregivers, or more to the point, who's physically able to do the job. We can move on to the next slide. Sticking with age and risk factors, we see this pattern intensify more as we look at those with multiple risk factors. Those under 45 were 40% more likely to have multiple risk factors compared to all adults. Again, we see a moderation of this relationship around middle age, and for those 65 and older, it's completely reversed, and we see that dementia caregivers are 17% less likely to have one risk factor compared with all adults. Or multiple, I'm sorry, this should be multiple. We can go to the next slide. So to dive a little bit further into what is driving that relationship at age, I looked at specific risk factors. So we note that dementia caregivers under the age of 45 compared with all adults are 86% more likely to report smoking, 46% more likely to report hypertension, and 29% more likely to report sleep. By the time that we get to middle age, 2 of those have moderated. Dementia caregivers are still slightly more likely to report smoking and hypertension, but nowhere near what we're looking at there. And the only difference that remains similar is that dementia caregivers are still 30% more likely to report poor sleep in middle age. By the time we get to those 65 and older, here's where we're starting to see dementia caregivers be less likely to have risk factors. Diabetes being the one they're most likely to have, the least likely to have compared to previous ages, but smoking being the greatest change, whereas those under 45 were significantly more likely to smoke. We're now seeing those 65 and older, the dementia caregivers, are significantly less likely to smoke. So that's a little bit about what's driving the age flip among the individual risk factors. We can go to the next slide. So headline conclusions. More than half of both dementia caregivers and half of all adults have at least one risk factor for cognitive decline in 2021 and 2022. So the range of potential interventions and groups that we are meeting with them is broad. And between 1 in 4 and 1 in 5 had multiple risk factors. So expect to hear and see more about multi-pronged intervention approaches going forward. Dementia caregivers had higher prevalence rates than the all-adult averages across 5 out of the 6 risk factors. Again, the exception was physical inactivity, but for those listed here, dementia caregivers were more likely to have all of these risk factors. We saw that male dementia caregivers, American Indian Alaska Native dementia caregivers, and Black dementia caregivers were more likely to have at least one risk factor compared to other dementia caregivers. That's aside even from all adults, but compared to other dementia caregivers. And then similarly, compared to other dementia caregivers, younger dementia caregivers, defined here as those under the age of 45, were significantly more likely to have risk factors, particularly smoking and hypertension. And again, we saw that relationship reversed among those 65 and older. So all in all, these findings give us a base of populations that have elevated risk compared to even other dementia caregivers. And luckily or unluckily, some of these groups are pretty broad, and we can reach a lot of different people by targeting these groups in particular. And I think that's it for me. Turn it back over to Kat.
Great. Thank you, Ben. Please add any questions for Ben you have in the Q&A box. And I also wanted to point out that the Alzheimer's Association released a press release about the data shared on today's webinar. The link to the press release, along with the full report on the data analysis, will be shared in the chat and in the follow-up email. And now I will turn it over to Renee and Patty to hear about how the Minnesota Department of Health is using BRIFIS data to support caregivers.
Thank you, Kat. I'm going to kick off our talk today, and just to give you a little background, we are going to keep talking about caregiving data. It'll just be a slightly different perspective on it. It's coming from our perspective as a state health department. So maybe some of the underlying features we'll talk about will sound kind of familiar to those of you who are in a public health department, aging services group, or community-based organization. So we titled this "The 9 or More Lives of Our Minnesota BRFSS Caregiving Data Analysis." So next slide, we'll tell you a bit how we approach this analysis. We first decided that we were going to think about this from a whole person perspective. We've heard from a lot of community partners that we've engaged that they appreciate our chronic disease programs, but they'd really like for us to talk about conditions altogether. Think about the whole person and everything that's going on with them. So we sought to bring that perspective into how we framed our initial caregiver analyses. Next slide. Another perspective that we brought to the table is that caregivers are a really important source of support for people living with chronic conditions, and especially people who are living with dementia. And their needs are a whole lot broader than just respite services. Sometimes that's what we hear again and again and again. And in alignment with some of our BOLD activities, we wanted to expand the conversation. So we wanted to make sure that we were capturing more than just need for additional services. So that takes us to our next slide. And some of the ways that we framed our analyses. Again, this is just a really basic descriptive analysis that I'm kind of sharing with you as the basis for our work. We looked at a lot of demographic characteristics that you might look at: age, gender, geography. And then we thought, this is BRFIS. We've got all these other modules. We're going to pull in some of the social determinants of health data that our BRFIS coordinators have been adding in over the years. And that'll give us a broader look at what our caregivers are experiencing as a whole person, right? What does their economic picture look like? How are they integrated in with communities to the extent we can assess that? What might their healthcare access be like? What's their educational status? Next slide, please. And what we saw in our just real basic descriptive analysis is that there were differences when we compared people who identified as caregivers and those who didn't. So all of these pieces of text that are bolded show differences that are, air quotes, statistically significant at a level of p.05. So there's something different among our population of caregivers. They are delaying care because of costs. They tend to have lower education, and we focused in on people that we felt were probably very likely to be through the core of kind of their educational series, if you will. They were more likely to be working aged and unemployed or not employed. To have lower incomes and to report not having enough social and emotional support. Next slide. And we went and then looked at a range of different health conditions, some of which you're seeing on the slide, and some of which echo the analysis that our colleagues just shared, looking at things like smoking that are risk factors, drinking, depression, mental health, as well as chronic conditions. And what we saw in many of these conditions, as you can see for history of depression, self-report of 14 or more poor mental health days per year, and smoking, is that caregivers have a higher burden of these conditions. And the same thing maps on for chronic conditions. So next slide. Part of our task was to kind of unpack what we did and think about how we used it, and we shared it. So we'll show you how we use this one descriptive analysis, and it's taken on many lives. Next slide. So we started off with a real intense conversation. I think Patty can remember back to me starting in this role and me really grappling with, I have a sliver of my time to devote to this new topic area that I don't know as much about. I'm really excited about it. How do I use this time well? And we centered on the idea of getting some data, some really foundational statistics that we would want to share related to Alzheimer's and dementia in Minnesota. So we talked about a fact sheet, which may sound familiar to lots of you. So what we're showing you is the first page of a fact sheet. A lot of the information comes from that wonderful document that Dr. Gogler referenced at the beginning from the Alzheimer's Association Facts and Figures. Really some level setting about what the condition is, how common it is. And then we started to use our own data analyses to build out some additional pages that can get mixed and matched as needed with this basic information. Next slide. And that's where our caregiver data starts to come in. So these are the other 2 pages of our fact sheet, which you can use independently if you'd like. And the first is about risk factors for living with dementia. And you can see a box that's focusing on high blood pressure prevalence, diabetes, smoking, lack of physical activity, and some information about screening and early diagnosis. And then switching to look at the right side of your screen, you'll see some data that's talking about chronic conditions and then what caregivers need in the bottom, more relevant to our conversation today. So where we really drilled down for this fact sheet was, what are those things that are popping out of that analysis? What's connecting with themes that we're hearing in community with some of the programs, the resources that we can connect people back to in our programs at the health department. And that connects with our partners' work. And we landed on the 3 items that are in these blue boxes across the bottom, elevating that caregivers, in this case, dementia caregivers, are more likely to have a history of depression. They're also more likely to report symptoms of current depression, which is another analysis. They're more likely to report having a chronic condition, many of which are dementia risk factors, and also for needing additional support. So this gave us our base messages, if you will. And then next slide. Thank you. Time unfolds, and we got creative about how we can go back to this core analysis that we did in these messages. So number 1 here is that we really grounded that fact sheet in 3 facts that we could pull out. We took some of those facts as well as some other pieces from that analysis, and we kind of peppered them in with some of our Gov delivery communications that we have, just elevating that data, small little bite. We had a student worker who was working with us, and we packaged this analysis and took it to our state gerontological society meeting to make sure people in the community knew that we had data on caregivers in Minnesota and what the picture looked like. We shared it with our state board on aging, and also began that conversation there. How can we use this information to support our work? And that opened the door to us getting an invitation to a new community-wide project they were starting, focusing in on caregiving. They invited us into the work group, particularly the data work group. And our BRFIS coordinator was fabulous and came out and shared what the BRFIS module was, how it could be utilized. We shared some of the main points from our analyses, and we built out some thoughts that'll support this initiative that utilize a variety of data sources, including BRFIS. We've shared it with our dementia work group, who's trying to pull out some high-level population indicators to help guide the dementia work. And through our conversations, they decided that they didn't want the dashboard framed just around people who were living with dementia, but they wanted to call out the general population and then caregivers as a specific group. So I appreciate this data and opportunity to do this kind of work to bring that front and center for us and for our partners. So caregivers don't just get buried in people with dementia getting what they need, but they can be elevated and brought up as a group that we need to focus in on in our strategies. We shared with some of our chronic disease programs, and a lot of it, honestly, it's just kind of been like cups of coffee relationships that we already have, right? And sharing some of this stuff planted some seeds, and our cardiovascular health program knocked on our door and said, hey, we have a student who'd like to take a look at this data and look at cardiovascular risk factors. So Patty and I, provided a little context. We shared analyses, we gave some feedback, and they came up with a great report that you can find on their website. I'll drop it in the chat later. And then we partnered with some lovely folks that we met from the Rosalind Carter Institute for Caregivers. And they offered us an opportunity, kind of like this one, to share a little bit of what we were doing as a state health department to elevate caregivers in public health approaches. So this is all one analysis and just kind of holding it open, knowing some of our key messages and trying to use it strategically. But it's not all on me. Actually, who does some of the really interesting work is Patty, and I'm going to turn it over to her.
Thank you. Next slide, please. Yeah, so when Renee and I were working on this presentation, Renee, I think, sent me a Teams message saying, I think we might have more than 9 lives for our caregiver analyses. And I was trying to think of all the ways that we've used this analysis. And as you can see, 7+ more lives. And I think Renee mentioned that we, for a long time, had a sliver of epi time on our aging team working on dementia. And we've been a small team since we've been a team, like a few full-time staff. So we kind of rely on, reusing, recycling our data presentations. And there's been many ways that we have been able to elevate caregivers as a priority by using this data analysis. And so some of the ways that we've used it outside of those sort of key opportunities to present data specifically is we have used the data in our Healthy Brain Community Grant RFP background section so that our applicants can understand the need to prioritize caregiver health and well-being and to understand the why behind that strategy in our Healthy Brain work. We've been able to present at multiple community meetings, including a caregiver conference up in northern Minnesota with a couple of our and partners. We were able to present about caregiver mental health and social support needs during a risk reduction webinar series last summer with the Alzheimer's Association. And one of my favorite ways that we've used this data presentation is with our local public health partners and their I think it's just really important as a way to elevate caregiver health and well-being as a public health issue across our entire public health system. There's a lot of engagement from local public health in this topic, and those have been more formal and more casual opportunities. And another important way we've used information is to educate policymakers on the need to focus on caregiver health and well-being. And I think what's not on this slide, but is equally important, is the kind of like constant conversation and ways that we bring this up internally at MDH. So with MDH, in meetings with MDH leadership across the Health Improvement Bureau, I think it's a topic that is becoming kind of like natural and front and center in our health promotion and chronic disease division. And I think we really owe that to this initial analysis and fact sheet, and just continuing to bring it up and talk to partners across the agency. I bring it up in work group meetings, like with our statewide health improvement framework, focusing on the topic of, in a work group focusing on the topic of mental health. Just, anytime we're talking to a new partner about what we do at MDH around brain health and dementia, we talk about this caregiver health and well-being data. So it's been really fun to just be able to elevate caregivers as a priority population. And just, paint that picture that has, I think for a long time been like, yeah, it's stressful and it's rewarding, and people need more support. But there's other audiences to reach with this information, I think, like primary care providers that can offer, maybe they're not in the business of being able to change policy or offer respite services, but they can do something. They can understand that if there's a caregiver, they may be experiencing social determinants of health that are, different than non-caregivers. I think we can go to the next slide. Renee's going to take this one.
Sure. So one of the great things about a presentation like this is it forces you to step back and kind of reflect a little bit. So thank you for that gift. So some of the lessons learned that popped up for me as I was reflecting on this was a newer way for me to tackle an analysis. Usually I'm kind of like a pig in mud and I want to analyze everything on the planet, because it's all exciting and it's all new. But I had some bounds on my time. So how can I approach this in a really intentional way? And I feel like it was helpful. It was helpful for me to ground myself in the topic, to force me to have some conversations with other people who were actually doing the work to guide the analysis in different ways, and to think about how we would use it practically and have that filter back. And I think I need to lean into it a little bit more. And the other thought about this is that, this model worked because we just have some coworkers and partners who are excited about data, and I think invite us into these use conversations, and we don't shy away. We'll take good feedback, when we get invited to share or play around a little bit with how we could explain it. We try to engage. So it was a great experience. And thanks for letting us share. And Patty's going to turn it back to all of you, because we've got lots of wisdom in the room.
Yeah, so we're really interested in how others have used their BRFS as caregiving data or other sources of data to prioritize and elevate the importance of caregiver health and well-being, and especially how you might be using data to kind of move the conversation beyond talking only about respite services. But like I said, are there other audiences that you're able to connect to using using data about chronic conditions and depression and smoking and those types of risk factors for caregivers. Not sure if we're going to unmute or ask in the chat, but.
Thank you, Renee and Patty. If you would like to enter your answers into the chat, we'll monitor those and would love to hear from you.
Great. So I think we're gonna do some Q&A. So please feel free to type those examples into the Q&A box, and I will add them to the list of really wonderful questions that we have so far. But Kat brought up a great thing, which is many of you were sharing your own personal experiences with caregiving as we've been listening to our great panel. So I wanted to take just a minute and put some resources into the chat, and we can add these to the follow-up email as well, that are resources for caregivers. So the Alzheimer's Association has a new app that is amazing. There's the 24/7 helpline, and then I also just included the website about caregiving there. But Joe, I'm going to start this first question with you, which is, do we know the incidence of dementia among people who have been dementia caregivers?
I have not seen I think a study I'm comfortable relaying as of yet with that in mind. It's a great research question. There may be studies out there I'm just not aware of too. I mean, so let's be clear. It's unknown, honestly. Is caregiving itself, or specifically dementia care, does that then place one at greater risk for dementia or perhaps even cognitive decline or subjective cognitive decline? You would think with some of the findings you've seen here today, as well as maybe even some of the more complex processes that could lead to potentially adverse health, at least for some caregivers, would probably at least contribute to risk profiles. But again, when we move beyond these cross-sectional comparisons and we start looking at longitudinal analyses or considerations of dementia caregiving health risk, it becomes a more complicated question, I think. And I know I'm punting a little bit instead of answering this head on. It is a great research question. Again, it's not one I've necessarily found data, for example, or studies where they would be able to make their way into the caregiving facts and figures section. If I did, I'd put them in there. But it's something that I think still needs to be determined. And it's related to some of the Q&A I saw too. Not only, right now, what you're seeing are comparisons, and you see a difference in the health outcome between a dementia caregiving sample versus a non-dementia caregiving sample. Perhaps they're representative, but there's a need to dig a lot deeper into the process that's leading to the health outcome. I saw Dr. Peter Vitaliano is on, and he had a very good question in the Q&A about, really the potential interactions between dementia caregiving and certain conditions or health issues that they could contribute to a larger chronic condition. We have a long way to go to really fully understand those processes. And when you add on top of that, social context, the context of dementia caregiving, where someone is caring, and how that may also contribute to health, you can see how it really necessitates a socio-ecological perspective, I would argue. Those are just my thoughts.
Yeah, and really the Q&A box is full of amazing research questions. So if you're wondering why there's so many we haven't answered, it's because I think there aren't answers to them yet. So please scroll through those Q&A questions for some really great research questions that need to be investigated. To that point, Ben, I wondered if you could talk just a little bit more about the limitations of your analysis with the BRFSS data. So just summarizing a couple of the questions in the box, we had one asking if any of the findings were statistically significant. Another asking if you had looked at people younger than 18, if we knew when people were diagnosed, meaning like what Joe was just mentioning, either before they were a caregiver or after. We saw from Renee and Patty that you can look at the social determinants of health with BRFSS data, so that was great to see. And then another great question of if you were able to look at any premature death associated with being a caregiver. So I thought maybe you could just talk a little bit more about the limitations of that data set. And yeah, then Joe, feel free to add in too.
Yeah, hopefully I can remember all of those questions right now. But let's see. So under 18, BRFS does not capture. So that there's no under 18 individuals in BRFS. Findings that I called out in text with a proportional, I remember saying, for example, those under 45 are 40% more likely to report multiple risk factors. Those were statistically significant. But again, these are just rough comparisons of confidence intervals because these are two estimates from the same sample from the same year, as it's really a snapshot. So it's a loose formula, but yes, they were statistically significant in those cases. What else, Shelby? What else?
Yeah, I think I do want to say a little bit about why the report online focuses on the risk factors, like why we chose the risk factors that we did versus
Yeah,
some of
absolutely.
the
So
data Renee and Patty showed that there is more information in the BRFSS.
yeah, so there definitely is a lot more information in BRFSS, specifically depression. Comes to mind, and the analysis is entirely possible in that case. We, in doing it as a combined project between the Center on Risk Reduction and the Center on Dementia Caregiving, look specifically at risk factors that we have high confidence in or high amount of evidence that there is evidence for future dementia related to those. So the evidence is a little bit less clear on depression on that front. I did see something about SDOH, social determinants of health, come up. So that's definitely an emerging area. BRFS is just now introducing a new module on social determinants of health. So we'll see new findings on that coming out of the next couple of years. Certainly relates to quality of life in the same way that some of these chronic conditions do and overlaps there. Also on the caregivers experiencing dementia, again, we'll see more in the next couple of years. We're seeing the subjective cognitive decline module has been increased in uptake around the states in the same way that the caregiver module is. We're waiting to see some better alignment of states in the year so we can do sort of the national analysis of subjective cognitive decline and caregivers all at once. But that is something that is in the future to come.
Joe, anything you want to add in?
Yeah, I wanted to address this really good question about mortality in dementia caregiving. Again, BRFS is not set up to do that because of its cross-sectional nature. However, this is an interesting, and this came up several years ago with our facts and figures team. There was a statistic floating around, and I actually heard this beyond the facts and figures team when I was in some meetings where people were saying things like, well, dementia caregivers are more likely to die than the person living with dementia. And I always thought that didn't make sense to me because, we know, for example, a high percentage of dementia caregivers are actually adult children. And to think that, even though it's stressful and challenging, to think that an adult child dementia care is going to die before a parent, to me, seemed far-fetched. And so I actually did some digging, and I actually heard people quoting this on CNN and like public media, and it never made sense to me. And we did some digging, and what ended up happening is that someone misquoted a pretty pivotal study that came out, I think, in 1999 that Scott Beach and Rich Schultz did on caregiving and mortality. And it was simply, that study wasn't inaccurate. It was that someone took a statistic and didn't interpret it correctly. It ended up on a website, and it just took on a life of its own. So we actually, in responses, we actually did a study looking at how often did dementia caregivers die before the person that they were caring for. We used health retirement survey, so we actually focused on spouse caregivers, because if there is a caregiver that would be more likely to die, would be a spouse than say an adult daughter or other adult child. And we found that it was roughly 18% of spousal caregivers, people living with dementia, died before their loved one with dementia, which is not insignificant. I mean, that's considerable, but it's nothing like, I think the stat people were throwing out stat like 69 or 70% of dementia caregivers die for the person, which just is not true. So that hopefully provides some clarification. If I had the ability to chat to everybody, I'd share with you the study itself. You can see it. But nonetheless, that's what, when you think of mortality and dementia caregiving, hopefully that clarifies that a bit.
Yeah, and we'll package up all these resources in the email that will go out to everyone who registered for this webinar, including the recording and any other information. But Patty and Renee, I'm going to give you all the last word. There's a ton of great comments in there about data's great, but we need some action. I wonder if you could talk about how the analysis you did has sparked any conversations or action in the state of Minnesota.
I don't know. I guess I could some of the things that really stand out to me. I'm really proud of my colleagues at the Department of Human Services. So in Minnesota, Human Services and Health are two separate entities, which has good and bad features associated with it. But they've been really open to learning about what the health department is doing, how we can collaborate. They were very interested in BRFIS as a data source, what it can tell all of us, and incorporated us into their work group. I love the fact that the work group has come out with a frame that's focused on caregiver well-being. Right? It's not just on the traditional receipt of services that programs can receive, but panning back to that whole person perspective. I think that's huge. It may not sound like a lot, but it changes the questions that get opened and the framing of a bunch of issues. And in a similar way, we had an opportunity to bring this information into a legislative task force that was created related to aging, and to put the issue of caregiving out there into the conversation with some of this data that we have at a state level. The research is fabulous, but it's usually focusing in on a smaller population in a defined geography. And with all the limitations that BRFIS has, it is probably the best sample of the whole state that we have at this point in time. Health systems don't collect data systematically about whether or not somebody's a caregiver in a way that you can pull information. It's a glimpse. It's starting to tell us where the pain points and the opportunities might be. And we're going to keep using it to elevate the need to go deeper.
I also think that during the last couple of years, we've had a legislative task force on aging in Minnesota, and I think between Dr. Gogler and Renee presenting to the task force with this frame about caregivers being a social determinant of health, it was a very new frame and different than some of the other testimonies that the task force was learning from. And so that seemed like an area that has some potential significant impact, to prioritize this issue. And then I think the other area would be in our Minnesota Dementia Strategic Plan. Anywhere where it talks about caring for people living with dementia, it includes, and their families and their care partners and their caregivers. It's kind of just baked into all of our strategy that we're thinking about both the person living with dementia and the care partner.
Thank you all so much for all this great information and sharing your experiences. I know this caregiving it's a great entry point and a wonderful bridge between multiple departments. Almost all of us have experienced it at one point in our lives or will experience it. Kat, I'm going to turn it back over to you to wrap us up.
Thanks, Shelby. And thank you everyone for your great comments and just overall thoughts and participation, as Shelby mentioned. To stay connected and hear about upcoming opportunities like this and others, you can subscribe to our monthly public health e-news. There will be exciting things launched in the near future, so you can always stay in the know by that way. And there's also, for further learning, you can begin the free innovative online module that addresses the role that public health plays in supporting dementia caregivers. Shelby will share that link in the chat, and it will be shared afterwards with the recording of this. And also, just wanted to point out again the resources that Shelby dropped in the chat previously for caregivers. We have the Living with Alzheimer's for Caregiver series with modules for the stages of Alzheimer's. And then, of course, our 24/7 helpline, which is free, and that's 800-272-3900. We hope that you enjoyed today's webinar. Have a wonderful rest of the day and take care.